Okay, guys, time is really prescient. I know it wasn't 2 minutes, it's more like 30 seconds, but there's a lot to get through, you'll see. We did start a bit late, but that's no excuse for me overrunning. There's a lot of stuff to do. Those who want to stay, I'd be very grateful. But there really is a lot of information, so let's get cracking. Disease of the large airways, 2 of them, asthma and COPD. Okay, first we'll do asthma. What is asthma, apart from someone who wheezes but is not necessarily a smoker? Well, asthma is a chronic inflammatory condition of the large airways, okay? And there is a global initiative for asthma definition, or a gene definition that you can look up when you're at home. But basically, any definition I think is good that says that there's a complex interplay between cellular elements and cells, and it's characterized pathologically by bronchial inflammation, eosinophil infiltration, and airways remodeling, and that usually the form of fibrosis. It can also be characterized physiologically by airways obstruction, bronchial hyperresponsiveness, and very thick mucus production that can sometimes cause airways plugging. Clinically, though, you're going to see cough, chest tightness, wheeze, and a feeling of shortness of breath. I'm going to talk about 2 things, chronic asthma and acute severe asthma. Chronic asthma, the history may favour asthma because there are episodes of these symptoms. So it's periodic. You get episodic cough, chest tightness, and wheezing, and the symptoms are variable. There is a seasonal variation in those who have who are allergic to pollens, and there's also variation throughout the day as well. And there are many different triggers for asthma: cold-induced, exercise-induced, lots of different allergens to pets. Probably the effect of house dust mite is probably overstated. I think we're finding now, since we've got allergy testing, that there are things that are becoming more important. Sort of epidemiology is changing, perhaps. Pollens are important, and non-specific irritants, especially cigarette smoke. There are various diagnostic pathways. The British Thoracic Society has one. Lots of books offer this to help you differentiate asthma between other things, because it is a clinical diagnosis. But when you find someone with asthma, or you've got some asthma you're reviewing, there are 3 questions that you can use to answer the question, how well controlled are they? And these are from the Royal College of Physicians. 3 questions are, have you had difficulty sleeping with your asthma because of your asthma symptoms? Do you get the asthma symptoms during the daytime? And has it interfered with your usual activities? I like this one, BTS likes this one, because it's simple. And you'll see that a lot in respiratory medicine. Simple things tend to stick. You can have a very glorious questionnaire that predicts it very well, very accurately, but no one's going to use it if it's over complex. So we like simple things. That's good. Examination, frequently normal in chronic asthma. We'll go on to acute severe later. There are signs. Don't worry about scribbling all this down, because we're going to publish this on the PodMedics website. So I'm going to fly through some of the slides, but just try and bear with me. But you may see signs of hyperinflation if they've had asthma for many years, kind of like the X-ray we saw earlier. And wheezes, so you get expiratory. A wheeze is an expiratory noise. It's usually described as musical or polyphonic, and it's diffuse, so it's all over the chest. And you may see signs of eczema and conjunctivitis if it's sort of seasonal allergic rhinitis and hay fever and everything that may suggest they've got some ATP, which is again associated with asthma. Examination, though, is helpful to exclude an alternative diagnosis, and some of the things you're going to look at we'll go on to later, but alternative diagnosis may be favoured where there's atypical symptoms. So perhaps you might have a cough without the wheezing. That doesn't favour asthma. If there's any disturbance of the voice, if they don't have airways obstruction on spirometry, there's no variation. That suggests more COPD or heart failure, something else going on. And there's no relief with a beta-2 agonist, and we'll go on to the treatment a bit later. And these symptoms favour an alternative diagnosis, and or maybe perhaps a past medical history of smoking or previous cardiac disease, be that an MI or hypertensive heart disease or whatever. And examination, if you find things other than a wheeze, this suggests another diagnosis. So if you find bibasal crackles, you need to be thinking heart failure and such like. And any features associated with cardiac disease, so if they've got peripheral edema, well, they might have 2 diagnoses, and that may complicate things, but just be aware of that. So these are the conditions that you want to consider. COPD, they're commonly confused. You get some 70-year-old come in, and she's been a pack-a-day smoker for 60 years, and the GPs diagnosed her with, nothing against GPs, a lot of them are brilliant, but the GP may have diagnosed her with asthma. When it could be late onset asthma, but clearly there may be something else going on here like COPD. Heart failure is another one, bronchiectasis, reflux disease, pulmonary fibrosis, large airway obstruction, quite rare, and a bit of bronchiolitis, don't worry about that. So there are lots of things that you need to consider. Investigations, again, they're frequently normal. Use our systems for looking at cultures, bloods, imaging, scopic and biopsy tests, and also functional tests. And functional tests we're going to hit. But the main things we're going to want to know are the spirometry and the peak expiratory flow rate. They're the main tests that we're going to want. We're also going to want to look at peak flow variability. That suggests someone who's uncontrolled. We're going to look at their responsiveness. So we can do functional tests like see how they get on with a bronchodilator. Does that improve their symptoms? And we can test that clinically in the lab with spirometry. Do spirometry before, give them bronchodilator, do it afterwards. If we want to be mean, we can do it the other way around. We can give them a histamine or methacholine challenge and give them some bronchoconstriction. And if they get worse with those, that suggests asthma. But also you can do a trial of steroids. They're on the diagnostic pathways as well. So this is the spirometry as we've gone through before. So low FV1 in relation to their FVC. Management. There are 3 goals of asthma treatment. One is to control the symptoms. It's not nice having asthma symptoms. You want to control them. You want to prevent exacerbations because they're a significant cause of morbidity and mortality. And we want to reduce the airways remodelling that happens because the more remodelling happens, lung function declines, and we want to prevent that. And there are various different methods that we can use. This doesn't project very well, I'm sorry, but you can look it up. It's free. It's the British Thoracic Society guidelines, and this is for chronic asthma, and it follows a stepwise treatment. So first of all, for mild intermittent asthma, we use an inhaled beta-2 agonist. And I like to think of asthma medications in sort of 2 ways. If you think of the autonomic nervous system, you've got a sympathetic and a parasympathetic nervous system, okay? The sympathetic is known as your flight or flight system. It's coined that, and that's the kind of system you want predominating when there's a big tiger or big dog you want to run away from. So you get all the things that would help you run away from a big dog. You've got wide eyes to see where it's coming from, so your pupils dilate, your airways dilate, your cardiac output increases, and all the blood's diverted from the peripheries to your muscles in your heart. Conversely, parasympathetic can be remembered by rest and digest, so does everything opposite to the fight or flight response. You get dilated pupils, you get bronchoconstriction, decreased cardiac output via the vagus nerve, etc., etc. So the way to think about drugs for asthma are we can either stimulate a fight or flight response, and adrenaline stimulates the beta receptors and alpha receptors, so we can use a beta agonist. And beta-2 is found mostly in the airway, so we can use a beta agonist. We can stimulate the sympathetic nervous system in a very specific way using these beta-2 agonists. The other thing we can do is inhibit the parasympathetic nervous system, the one that causes bronchoconstriction. And we do that by anticholinergics, because if you remember, acetylcholine is the main neurotransmitter involved in parasympathetic nervous system. So beta-2 agonists are the first thing. If they're not controlled on that, we move to step 2, and that's regular preventative therapy in form of a steroid, and that reduces the airways inflammation and hopefully prevents the system. Step 3, we add a long-acting beta agonist like salmeterol, and there are also other things we can do here that I don't want to go into because they get complicated. And then by step 4, we've got persistent poor control. This should be under the care of a respiratory physician at this point. And there are lots of things that we can add in: chromoglycate, leukotriene receptor antagonists, and all the rest of it. And step 4 and 5, we're getting into quite serious asthma symptoms, and they should be under the care. Acute severe asthma is poo your pants scary. Okay, if you see it on the wards, these people can go off in a matter of minutes, and there's a lot of panic associated around it. And it's important you take care of these patients properly, even if they initially look well. And one of the things when you first see someone in an acute severe or life-threatening asthma attack is, oh shit. And that's not me being profane. That's a mnemonic that I want to bring up a bit later for remembering how to treat acute severe asthma. I hope you remember it. Another mnemonic I'm going to introduce you now is MOVE, and this is what I want you to remember for when you see anybody who's acutely unwell, and it stands for monitor. So you want to put the monitor on, 3-lead cardiac monitoring, have a look at the ECG trace. We want to monitor their blood pressure and pulse oximetry, very important. Oxygen, these patients are going to need oxygen. They need venous access. Some of the drugs and fluids we need to give go via the veins. They need venous access. And an ECG. They all need a 12-lead ECG in addition to the 3-lead cardiac monitoring. So remember those 2 mnemonics when you're dealing with acute severe asthma. The first thing you should do is assess severity. Probably won't be able to get a very good history, so make it concise. They're very short of breath. They're not going to be able to sit and have a chat about where they went last year on holiday and everything else. So just get a very concise history. And the things you want to pick out is this patient at risk of going to ITU? And risks for demise include previous ITU stays, previous mechanical ventilation for asthma, not after the car accident or anything like that, but for asthma specifically. And if they've been admitted recently for asthma in hospital, say they came in 2 weeks ago for asthma control, now they're back in again, that's a risk factor for demise. You want to get those things down very quickly. You also want to try and exclude anaphylaxis, so maybe a bit of an allergy history and what they've been exposed to very recently might be very good as well, because that presents with very wheezy. And quick examination, you want to look at their consciousness, heart rate, blood pressure, respiratory rate, have a look at their chest expansion, how much air is going in and out, assess for a pneumothorax as a complication of asthma. Again, we've said exclude anaphylaxis. And these are the investigations we've done. We've already got the oxygen saturation monitoring on if we've followed the MOVE mnemonic. Peak expiratory flow rate, that you might be able to do that, and they may be too unwell. And they usually try and find out their best peak flow and usually express what they are now as a percentage of their best. We'll see that in a moment. Arterial blood gas, if there's signs of hypoxemia. So low oxygen saturation below 92, you want to do blood gas to assess their ventilation and their oxygenation. And a chest x-ray, everyone doesn't need one, but if you think it may be indicated in like a pneumothorax, or maybe you think there's a pneumonia or something else going on in an asthmatic. These are the BTS guidelines. Just want to flick through the first bit really. And this is the classification. I hope you all can see this. There's a moderate, acute severe, life-threatening, and a near-fatal asthma attack. And that's how we should classify it. So a moderate exacerbation are people that may go to their GP with increasing symptoms. Their peak flow, though, is around 50 to 75% of their usual, their maximum. Or, if they don't know their usual, you can use their predicted value. And there's no features of acute severe asthma, which are, and these patients probably present to hospital, their peak flow is around 33 to 50%, so a third to a half of their normal, of their best and predicted. They're tachypneic with a respiratory rate above 25, heart rate above 110, and their inability to complete sentences in one breath. That's acute severe attack. It gets more serious when you've got other features, and there are a list of them. And if you've got any of these, it's termed life-threatening, and that's a further decline in peak respiratory flow to below 33% of their best or predicted. Hypoxemia, as evidenced by a low oxygen saturation, which is below 92%. Their PO2 on a blood gas, less than 8, so they're in respiratory failure. And if they've got a normal PCO2, if you think someone's breathless and they might be hypoxemic, they'll be breathing very rapidly. They're already tachypneic if they've got acute severe asthma. And if their CO2 is normal, when it should be low because they're breathing very rapidly, this is a poor sign. If it's raised, that's a very, very poor sign. And that's a near-fatal attack if it's raised. They may also get other things like cyanosis or poor respiratory effort, arrhythmia, and they may just be looking downright exhausted. I won't go through that. These are treatments that I'll go through in a nicer table. So this is the mnemonic I want you to remember, the OSHIM or OSHIT mnemonic, okay? Stands for oxygen, which hopefully if we followed the MOVE mnemonic, we'd already got on the patient. Salbutamol, you want to give this via the nebulized route, and you want to give it often, usually back-to-back if they're very unwell. Hydrocortisone is the H, but if they can take oral tablets, prednisolone is probably better, and a dose of, say, 30 to 40 milligrams is what you should be giving these patients, depending on their size. Ipratropium bromide, this is to inhibit the parasympathetic nervous system, as we said before, and they all cause a rise in intracellular cyclic AMP, causing bronchodilation. You want to give that, again, nebulized, back-to-back with salbutamol. And then you can use theophylline. It falls in and out of favour. Its use is controversial. Magnesium is coming much more into favour, though, and a 2-gram slow IV infusion of magnesium can cause, if patient hasn't got, if they've got, haven't got a high magnesium anyway. But you should, when you get to this point, the last one, I wouldn't, go around prescribing this. I would take senior advice. But certainly the first, O, S, H, and I, you want to be doing on your own immediately. Okay. And monitor these patients because things can change very, very rapidly. and they go down here very quickly. So make sure they're on a ward where the nurses know to monitor them very quickly. You don't want once daily observations. You want almost, half hourly and hourly obs.